ahead. You're on.
Okay, good morning, everyone. Good morning, Dr. Naka, Dr. Bernard, Dr. Stein, Dr. Xiao. I'm Belinda, and I'll be presenting on peripheral neuropathy, specifically small fiber neuropathy. All right. So before I go into the details of small fiber neuropathy, I'd like to mention a little bit on the overview of peripheral neuropathies and the different symptoms and how do we differentiate it. So we could differentiate by autonomic neuropathy, small fiber neuropathy, sensory motor neuropathy, polyradicular neuropathy, and motor neuropathy. So some of the differences are how they present the symptoms. So specifically, small fiber neuropathy comes with pain, allodynia, dysesthesia, paresthesia, and motor neuropathy comes with muscle weakness or atrophy, muscle wasting. Autonomic neuropathy comes with symptoms of GI symptoms, constipation or diarrhea, erectile dysfunction, urinary symptoms, orthostatic hypotension. So this is just an overview of peripheral neuropathies. So to go in further, what we're focusing on in small fiber neuropathy are the A delta fibers and the C fibers. And this table shows you the sensory fibers um, involved generally in neuropathy. But what we're focusing on is the A delta fibers and the C fibers. So how we differentiate these A delta and C fibers is how we sense. A delta senses sharp sensation and cold temperatures, while C fibers dull pain and heat. So these are how we can identify that the small fibers are involved in a patient. So nerve conduction studies and electromyography will be normal uh, when we assess for small fiber neuropathy most of the time. And if there is any abnormality on nerve conduction studies or electromyography, it would usually be the larger nerve fibers like A alpha and A beta fibers, which detect proprioception and vibration. So moving on. So these are some of the causes that are involved in a small fiber neuropathy. As you can see, it's a vast list of causes. And so we have to make sure we are really meticulous in looking out for the causes, and some are really common causes like metabolic causes, your nutritional deficiencies, your endocrine disorders, and toxin agents, especially alcohol. Um, the ones that are challenging is the idiopathic or cryptogenic, now sometimes known as apparently autoimmune because there are no known causes found to it, or the hereditary causes like the sodium channel mutations and amyloidosis, sarcoidosis, autoimmune conditions. So moving on, please feel free to ask me any questions as I move on. So because it is a very challenging neuropathy to identify and to diagnose and then treat, there are a few studies that came out with approaches to how you would diagnose this condition. Um, Firstly, it's always the history, and then your physical examination and your specific investigations. And this study was a study done in Italy, and they came up with uh, uh, the they came up with a method of how would you approach the diagnosis. So like I mentioned initially, small fiber neuropathy presents with pain and allodynia, a very specific kind of pain. Your quantitative sensory testing, this is specific investigation to identify the A delta and C fiber involvement in the small fiber pathology, as well as biopsy to figure out the intraepidermal nerve fiber density. So we would rule out anyone who has neurological impairment or any abnormality on sensory motor nerve conduction studies, because this would show an involvement or a concomitant large fiber neuropathy. So this is one of the questionnaires for neuropathic pain. It was created, or it was come up with in France, and these are the few questions that are very sensitive to neuropathic pain. So we would ask the patients 4 questions, and it is very suggestive if they score 4 or more. And so as you can see, it's 83% sensitive and 90% specific to neuropathic pain. And this would just be the screening for small fiber neuropathy. Right. So we could divide the symptoms for small fiber neuropathy into sensory and autonomic symptoms. Most of the time, 80 to 90% of the time, a patient would actually present to the office for a complaint of pain or dysesthesia or paresthesia, a sensory complaint rather than an autonomic complaint. So some of the symptoms would be pain, burning, painful cold sensation, shooting pain, crampy, pins and needles, allodynia. So what allodynia is, it's a sensation that comes on if there's a material or cloth or bed sheets rubbing on your skin. Hypoesthesia, usually cold, hyperalgesia. Some of the autonomic symptoms could be tachycardia or feeling faint while standing up from a seated position, having blurred vision, diarrhea, having hot flushes in changing temperatures, and dry skin or areas of not sweating. So there are a lot of diagnostic modalities available: laboratory, histopathological, neurophysiological, and imaging and genetic tests. So we definitely would like to try laboratory tests first. It's the cheapest, easiest access, and we could get the results the fastest. So we do the general bloods, CBC, your chem profile, and you can go based on that, your sugar levels, your nutritional deficiencies first before we go into further investigations. And skin biopsy would be one of the things that we'd like to do, because it would show you objectively whether you have the small nerve fibers present there or not. The other thing would be electroneuromyogram. Electroneuromyogram only shows us if there's a large fiber involvement. It does not tell us if small fibers are involved. It just shows us a concomitant large fiber pathology as well. So what we're trying to focus on here is for the small fibers, and some of it are laser evoked potentials, heat cold threshold, electrochemical skin conductance. So what electrochemical skin conductance is, the pseudoscan. We have it here at the clinic, and obviously imaging if the others do not show anything positive, and genetic tests if there are family histories of certain conditions. It's not done for everyone. So like I mentioned, electrophysiological investigation and nerve conduction studies, your electromyogram. It's done for large fiber neuropathy, just to rule out concomitant involvement of the large fiber. So laser evoked potentials. So what it does is it uses laser to stimulate your skin, and there are 3 primary outcomes. One of it subjective, asking the patient about your pain score, using numerical rating score. And the other thing is looking at the electrical outcome of it, the amplitude of the electrical transmission, as well as the latency of the electrical transmission. So it has both subjective and objective outcomes, and it's found that it's 70 to 80% sensitive for small fiber neuropathy. So what laser evoked potentials identify is any abnormality in the A delta fibers. So the fibers that detect the sharp as well as the cold. And the other thing we could do is a quantitative sensory testing. So this investigates both A delta and sensory C fibers. Um, so it's a very subjective test. It just applies a cold temperature to certain areas of the skin or warm temperatures, and the patient would actually say how hot or how cold it is. So that's why the sensitivity is very wide, 60 to 85%, and maybe not very reproducible. And then there are tests for autonomic function, pseudomotor function, your quantitative pseudomotor axon reflex testing. So this is the clinically most available test, quantitative pseudomotor axon reflex testing, and it's widely available. So what it does is it evaluates your sympathetic cholinergic function, and they use iontophoresis. What is iontophoresis is transmitting the chemical cholinergic agent through your epidermis, and this would stimulate your sweat glands to produce sweat, and the humidity is measured using a hygrometer. So it is found that it is 60 to 80% sensitive. A study done in Massachusetts General Hospital, what they found is using QSAR, 69% of the time, it found an abnormal finding when a patient had small fiber neuropathy. So it lies within the sensitivity of 60 to 80%. Um, and the other thing would be the electrochemical skin conductance scan. Um, what this does, it has some metal rods identifying your sweat production, uh, the chloride in your sweat using current. And this is about 80 to 92% specific in identifying autonomic dysfunction in small fiber neuropathy. So there are tests that identify cardiovascular function as well, but this is just doing an EKG and looking at the RR interval variation um, using Valsalva maneuvers. And you'll notice in autonomic dysfunction that the variation tend to reduce because they're unable to respond to the vasovagal changes or the dynamic maneuvers that are being used. And skin biopsy. Skin biopsy has always found to be the most uh, specific test because you can see objectively that the nerve fiber density has reduced in the epidermis or in the sweat gland. So the areas where the samples are taken from is usually the leg, the thighs, upper thighs, and mid thigh. So three areas to just show the difference in the density of the nerve fibers, and you can identify the small fiber neuropathy. So this image shows the top and bottom. The top shows a normal sample with the small nerve fibers, and the bottom shows diminished nerve fibers, if you can see. All right. So this is just um, a study done to differentiate the different modalities and the diagnostic efficiency of the different studies, and collectively how sensitive it is to identify small fiber neuropathy. So clinical examination, as you can see, the specificity is 46%. When they use quantitative sensitive sensory testing, it's only 36%. But the skin biopsy has always been the highest sensitivity and specificity of 80 to 90% in identifying the small fiber neuropathy because it is objective and you can see directly whether the nerve fibers are there or aren't there. Okay. This is another study showing the different sensitivities and specificities using individual studies or using combination studies. As you can see, nerve conduct in this study, this study was done in Scandinavia. Nerve conduction studies, the biopsy as well as the quantitative skin testing has 100% sensitivity. So like right here, compared to the other tests. So definitely you would want to incorporate few tests, your clinical, your examination, and a few of the specific tests, especially your biopsy. As you can see, biopsy alone is about 85% sensitive on this chart. All right. Okay. So now we have identified small fiber neuropathy. We have tried to investigate small fiber neuropathy for its causes and whether it really is small fiber neuropathy. And now we know what it is. We need to try to help manage it. And most of the time, we're managing the pain because that's what the most of the complaints are about, the pain. So pharmacologically and non-pharmacologically. So I'll go with pharmacologic first. The first line in most of the treatments for small fiber neuropathy would be anticonvulsants, the gabapentin and pregabalin. And then it would be the antidepressants, tricyclic antidepressants, amitriptyline, or your serotonin norepinephrine reuptake inhibitor, duloxetine and lefexine. And opioids are not used as much because number one, it would cause a dependent issue, and the other thing is it does not really have a role in small fiber neuropathy because it is just a depressant. And there are topical agents as well, capsaicin, lidocaine patches, or CBD oil. And the other thing that we should not forget about is psychological support, because the pain could cause psychological stress, and eventually the psychological stress could worsen the pain as well. And that's a very important issue to address as well. And physiotherapy as well. So what I'd like to talk about what's coming. So there's a study, it's only done on rats so far, the meldonium and acetylcysteine studied using in rat model. So this combination drug increases nitric oxide and improves microvascular function. So what I was thinking about is it might be good for something like diabetic neuropathy, where the vascular changes would also affect the neuropathy, and it would help in that. It's not done in any human study yet. The other thing would be the second drug, sibinetide. It's an erythropoietin-derived peptide. It has no erythropoietic activity. So it is found that it is an innate peptide that repairs the receptors and arrests injury and has cytoprotection effect and anti-inflammatory. So this is one of the new drugs as well. And then the most important thing I'd like to talk about is actually the immunomodulators. So right now we're thinking of intravenous immunoglobulin for this small fiber neuropathy, specifically for autoimmune or apparently autoimmune cause of small fiber neuropathy. Why I say apparently autoimmune is because there are no symptoms, there are no signs suggestive of autoimmunity, but then again, there are no other causes found from the extensive investigations that's done. So one of the studies, I think it was done in Massachusetts, they classify these patients as apparently autoimmune. And this study, it was done with 55 patients, and it was done over 2 years. It showed 74% of the patients recorded improved pain. Just so this is showing us that there is a role for intravenous immunoglobulin in the management of small fiber neuropathy, as specifically if you don't know the cause, or if there's an autoimmune component uh, for the small fiber neuropathy as well. Other than this study, there's another study done in the Netherlands for 60 patients. They have also found 73% of the patients improve in pain, and their other primary outcome was a biopsy, a repeated biopsy 3 months after the IVIG therapy, and they showed improvement in the small fiber regrowth. You could see the density changed after 3 months using intravenous immunoglobulin. So I've come to the end of my presentation. If you have any questions, but I'd like to say, but small fiber neuropathy is very challenging to diagnose. People go through many doctors before actually finding out that actually it's the small fibers that's causing their symptoms and the pain and all of that. So sometimes you have pathology and it's difficult to separate or segregate the treatments for it. And so we need more data on new therapies, specifically intravenous immunoglobulin, to actually show that there is a difference using it in treatment. All right.